Good morning, all respected. Good morning, Vice Chancellor Sir, Dr. V.K. Kapoor Sahab, Medical Director, our teacher, our mentor, our senior surgeon colleague, Dr. Jaiswal Sir, Dr. R.G. Sharma Sir, and all the dignitaries, my senior faculty members, students. जैसे कि बड़े शायद 5 या 6 साल से परंपरा चल रही है ना, CCR का दिस इज कंबाइंड क्लिनिकल राउंड and I think we have presented or we are going to present this 25th or 26th CCR from our Department of General Surgery. So just a brief introduction about our department before the CCR, and after that Dr. Neel Kamal team will present the CCR. This is our team and welcome you all from our team of General Surgery. What is team? Team is the collection of the person who are working together for a common goal. टीम में ऐसा जरूर नहीं है कि सब लोग जो है बराबर कैलिबर के हों या बराबर सैलरी हो या सबके डेजिग्नेशन बराबर हो. टीम के अंदर आपके प्रोफेसर भी आएंगे, एचओडीज भी आएंगे, नर्सिंग स्टाफ भी आएगा. बट कॉमन इज व्हाट इज कॉमन, गोल इज कॉमन. एंड व्हाट इज आवर गोल? टू इम्प्रूव आवर डिपार्टमेंट इन द क्लिनिकल स्किल, पेशेंट केयर एंड एकेडमिक्स. Department of General Surgery established in 2000 from the very beginning of this hospital, and I am very grateful and proud to say, and I usually say, I am the first person who joined this hospital in Department of General Surgery. I am the first person, and as Dr. Swankar is not here today, so I think I am the oldest person in this institute, in this gathering at least. So we have taught 21 batches of MBBS since first batch has passed in 2005. More than 2,000 MBBS, BDS and physiotherapy students have been taught. PG program was started in 2000, and I am again proud to say that we are from amongst the first to start PG in General Surgery Department, and we are the PG guide for this. We have 10 professors in our department, 3 associate professor, assistant professor, senior resident and PG resident, and I have already told you, this is our team, and team is for the common goal. We are very fortunate and lucky that Dr. Jaiswal, very senior surgeon, senior specialist, senior professor, our mentor, teacher, from AFMC Medical College, is as senior professor in our department as well as is the medical director of this institute. Other very senior faculty, Dr. Lakshman Agarwal, Dr. Rajkamal Kanodia, Shirish Gupta, Dr. Kochar, Dr. Burjesh, Dr. Saroj, and Dr. Neel Kamal Gupta, who is going to present this CCR today. Most of the faculty members are working for more than a decade. Few are working since last 15, 18, 20 years. We have increasingly trained in general surgery OPD as well as in IPD. From 2012, there were 5,000 IPD, 15,000 OPD. Now it's more than 21 OPD and 7,200 IPD. Procedure we usually performed, and again I can say that I have performed the first laparoscopic cholecystectomy in 2000, and after that we have performed more than 20,000 laparoscopic cholecystectomy and various other laparoscopic as well as open surgery. Common procedure performed by our department is open or lap cholecystectomy, laparoscopic appendectomy, hernias, bariatric surgery, laser varicose veins, laser fistula surgery, breast surgery, breast cancer surgery, and perrectal or anorectal procedures, very common. The Department of General Surgery offer a range of specialized clinic and subspecialties, including diabetic clinic, breast clinic, bariatric surgery clinic, hernia clinic, varicose veins clinic, plastic surgery clinic, surgical gastroenterology clinic, and pediatric surgery clinic. We have a very good infrastructure of OPD and our wards. We have total 240 beds, and this is one of the largest department of Mahatma Gandhi Hospital. Male has 130 beds and female ward has 90 beds, and 12 beds are in the surgical ICU. Surgical ICU again 15 beds and with a world-class care. We have telemedicine consultation, modular theatre, modular infrastructure. We have a very good Wi-Fi campus, access online resources on Nimbus and e-journals. Our department has modern and interactive learning facilities that make studying more engaging and practical. Academics, we have rotation posting for our residents in various super specialty departments like neurosurgery, pediatric surgery, ICU, emergency, CTVS, urology, plastic surgery, oncosurgery, trauma surgery, and gastrosurgery. Last CCR I have presented about oncosurgery. Dr. R.G. Sharma sir ने मेरे को फिर फोन करके डांटा था यार तो ऑन्को सर्जरी में बेचता तो है नहीं, तूने बोल दिया सर, मैंने आपके पास भेजना शुरू कर दिया रोटेशन में ऑन्को सर्जरी के पास। अब लास्ट 2 या 3 महीने से आपके पास जो है वो ऑन्को सर्जरी में रेजिडेंट आ रहे होंगे और दे आर वेरी हैप्पी। आई आस्क दैट रेजिडेंट, मैंने बेटा वॉश वॉश करने को मिला? बोला सर लगभग मैंने रोजाना एक नए केस में तो वॉश किया। तो थैंक यू सर। वी हैव बेटा प्लीज लास्ट बेंच प्लीज, है ना। वी आर ऑर्गेनाइजिंग a departmental quiz, mentorship and career guidance, journal club, periodic internal assessment, skill lab, simulation labs available, bedside teaching and walk down our routine. Interdisciplinary learning, as I already told you, we are participating in all activities, all academic activities of Mahatma Gandhi Hospital like UGCR, PGCR, CCR, and we have participated in more than 50 like that, 25 CCR and baki other procedures. Resident-led teaching session, this is a very regular basis in our department. Seminars, case presentation, etc. are going to. Monthly CME, as Dr. Kapoor has appreciated various times also. PS is a theme-based or subject-based CME we are organizing. Like we organize for abdomen, wound healing, laparoscopic hernia repair, benign breast disease, implant chemo port, role of laser in general surgery, how to prevent and manage CBD injury के ऊपर we have presented a total full day CME with the credit hours. Credit hours means these credit hours are given by Rajasthan Medical Council, and 3 credit hours are given to faculty members and 2 credit hours are given to delegates. And if some resident stay in our department for 3 years, he will at least get exposure of the 20 CME, means 40 CME credit hours to the resident and 60 credit hours to the faculty members. Monthly CME and workshop are routine feature in our department. Research and publication, since last 2009, we have published 107 PG degrees has been awarded and 107 dissertation have been completed. We have 63. We have a batch of 24 residents per year. So after 1 year, we will have 24 into 3, 72 residents. So 72 thesis or 72 research तो at least जो है वो हमारे डिपार्टमेंट एट ए टाइम जो है वो चल ही रही होंगी. Guest lecture with Dr. Ajay Kumar Sharma, he is transplant surgeon from UK. Various other guest lecture by Dr. Jitendra Chawla, Dr. S.S. Sharma sir, Dr. Rajesh Katewa, Dr. Prashant Lavania. We have got an award for maximum number of doing Bhamasha surgery from the central ministry, in a video conferencing led by, at that time, Health Minister Mansukh Mandavia sir. Department Achievement Award, we have got very Center for Excellence. Dr. Rajkamal has got Center for Excellence Award, and we ourselves as department has got the Chiranjeevi Award. Certificate has awarded, various awarded and received by our residents in various conferences. International travel grant was awarded by Japanese Surgical Society to our resident Dr. Paresh Sharma. Extension of outreach activities, celebration of national and international days and personal activities like Doctors Day, World Environment Day, World Teachers Day, No Tobacco Day, World Cancer Survivor Day, World Blood Donor Day, International Nursing Day, International Women's Day, International Health Day, World Hypertension Day. So we are celebrating almost all the possible, co-curricular activities in matches like cricket match, inter-college cricket tournament, inter-college football tournament, etc. Cultural activities, cultural days are not just because of fun and colors. They are about the connection. In the laughter and performance, we build bonds, and behind us stands our teachers, guiding, supporting, and caring like our parents. So making sure we shine not just on the stage but in life. The Department of General Surgery vision to be center of excellence in general surgery, delivering the compassionate, evidence-based surgical care, advanced innovative research, and cultivating the next generation of surgical leadership through outstanding education and mentorship. And last words to our students, and last CCR I think I have also told you, this is you who make our name. इंस्टीट्यूट की वजह से बच्चों का नाम होता है. आप कहाँ पढ़ रहे हो, आज आप किसी को जाओगे ऐसा महात्मा गांधी इंस्टीट्यूट है, दिस इज वन ऑफ द बेस्ट इंस्टीट्यूट इन इंडिया. बट नाम किसकी वजह से होगा? आप लोगों की वजह से. जब स्टूडेंट कहीं जाके कहेगा कि सर ही परफॉर्म दिस, ही गॉट दिस पद्मश्री, ही गॉट दिस पद्मभूषण, ये कहाँ का स्टूडेंट है? महात्मा गांधी का. तो महात्मा गांधी का नाम बेटा आप लोगों की वजह से होगा. जैसे मैंने पिछली बार भी कहा था, द्रोणाचार्य ने सबको सिखाया. कौरवों के गुरु भी द्रोणाचार्य ही थे. ऐसा नहीं है कि द्रोणाचार्य ने सिर्फ अर्जुन को सिखाया. तो आप में से ही कोई अर्जुन निकलेगा, कोई भीम निकलेगा, कोई दुर्योधन निकलेगा, कोई युधिष्ठिर निकलेगा, है ना। तो आप लोग जब नाम करोगे महात्मा गांधी का, तो आप किसी अच्छी जगह के ऊपर जाके योर डूइंग सुपर स्पेशलिटी, आप में से कोई कार्डियक ट्रांसप्लांट कर रहा है, आप में से कोई बड़ी सर्जरी कर रहा होगा एट दैट टाइम, तो यू विल मेक अवर नेम, नॉट अस विल गिव यू नेम. The Department of General Surgery, again welcome you all, and next Dr. Jatin Lakhani will present the CCR under the guidance of Dr. Nilkamal Gupta sir. Thank you very much.
A very good morning to all the respected dignitaries, senior faculty members and my friends. Today I, Dr. Jatin Lakhani, third year resident of Department of General Surgery, will present a case on a 49-year-old female with large abdominal swelling under the guidance of Dr. Nilkamal Gupta sir, Professor and Unit Head of Department of General Surgery. My patient, 49-year-old female, homemaker by occupation, resident of Bharatpur, Rajasthan, presented with chief complaints of abdominal swelling for 12 years, pain abdomen for 7 months and vomiting for 7 months. Patient was apparently alright 12 years back, following which she noticed the swelling over the abdomen. The swelling appeared from the umbilical region in the midline and was approximately the size of patient's fist. The swelling gradually increased over time to attain its present size. Initially, the size of swelling increased on coughing and walking and disappeared on lying down. But for the last 7 months, it neither increased on coughing and walking nor disappeared on lying down. Swelling was associated with pain in the umbilical region for the past 7 months. Pain was gradual in onset, colicky in nature, and mild in severity. Each episode lasted for few minutes. Pain was aggravated after taking food and was relieved after taking medication. There is no radiation of pain. At times, pain was associated with difficulty in passing, flatus and motion. Patient complained of vomiting for the last 7 months. The vomitus contained ingested food particles mixed with bile, and it was approximately half glass in quantity in every episode. Initially, the frequency of vomiting was 2 to 3 episodes in a month for the first 3 to 4 months. The frequency progressively increased to 2 to 3 episodes per week over the last 2 to 3 months. There was no history of hematemesis. Patient had history of multiple hospitalizations over the past 7 months. Initially, the patient required hospitalization once in every 2 to 3 months. It was progressively increased to 2 to 3 times every month. Patient was managed conservatively. Patient had undergone laparotomy in 2011 for query intestinal obstruction, for which the documents were not available. The post-operative period was uneventful. After 4 to 5 months of laparotomy, a swelling appeared from the midline laparotomy incision, and open incisional hernia repair, that is tissue repair, was done for the same. A swelling reappeared from the midline scar 8 months following open incisional hernia repair. Patient gave no history of tuberculosis, diabetes, hypertension and COPD. No significant family history was reported. Patient took over-the-counter medications for pain. She was vegetarian by diet, had no history of smoking or any addictions. The bladder habits were normal. She was gravida 3, para 3 with no history of abortions. She attained menopause at the age of 46 years and had undergone tubal ligation at the age of 34 years. Patient was examined in a well-lit room with proper informed consent in the presence of a female.
Hold on. So you need to analyze the history first, because that is what happens in the exam also. Once you have presented the history, the examiners will stop you and ask you, what do you think?
So sir, my patient presented with abdominal swelling for 12 years.
Don't repeat what you have said. This is another common mistake which you people do in the exam. We have already heard what you have said. Now I am asking you, how do you analyze that history? What is your interpretation?
Sir, as my patient had undergone laparotomy in 2011, following which a midline swelling appeared, and patient had undergone incisional hernia repair, following which a swelling reappeared. So my diagnosis, it can be an incisional hernia, and the abdominal swelling was previously reducible and it disappeared on lying down, and now the swelling has stopped disappearing on lying down, and uh, so it can be an irreducible incisional hernia.
That's all. What about vomiting, pain?
Patient also presented with chief complaints of vomiting and pain. So
Analysis,
the pain was
analysis. Don't repeat the symptoms.
intermittent and colicky. So due to this,
So the right answer will
is
be, I
subacute
think this is
intestinal
an
obstruction.
incisional hernia. It is a recurrent incisional hernia.
With
It has become irreducible and now it seems it is causing
subacute
obstruction.
intestinal obstruction.
Obstruction where?
In the small intestine.
Which part of the small intestine?
Sir, it can be either jejunum or ileum.
वो तो कोई भी बोल देगा क्योंकि दो ही पार्ट होते हैं स्मॉल इंटेस्टाइन के. You are a third year resident.
Sir, more commonly it is seen in jejunum.
Why? In this case,
The patient gave history of vomitus, which was bilious and associated mixed with food particles.
yeah, so it is proximal small bowel obstruction.
Yes.
Okay. So you said there is no history of hematemesis. Why do you think she should have hematemesis?
Sir, I asked this history to see if there is any pyloric stenosis or
The history is suggestive of pyloric stenosis.
no, sir, frequent vomiting episodes. were
There is
seen.
bilious vomiting. What does bilious vomiting indicate?
Intestinal obstruction.
Obstruction distal to
Till
the papilla.
papilla.
So why should there be hematemesis? If at all there is bleeding in the GI tract, in this case, what will it manifest as? Will it show as hematemesis? If there is bleeding from the proximal small bowel, what will it manifest as? What history the patient will give you?
Black stools.
Black stool. So that is more important,
Yes.
isn't it?
Yes.
Hmm.
My patient was examined in a well-lit room with proper informed consent in presence of a female staff. She was conscious and well-oriented to time, place and person. Patient was averagely built and nourished with a BMI of 23 kg per meter square. There was no pallor, icterus, clubbing, cyanosis, lymphadenopathy or edema. The vitals at the time of presentation were normal.
A patient who's been vomiting 2 to 3 times a week for last 2-3 months, go back to your general physical examination. What is the most important point in the general physical examination which you haven't mentioned? What is this patient likely to have? Patient who's been vomiting repeatedly, what is she likely to have?
Pallor.
Okay, but that you have mentioned something
Patient
which you
may
have.
also have dehydration.
Dehydration. You haven't mentioned anything about dehydration. It's very important.
Yes.
How do you see whether the patient is dehydrated on general
Sir,
physical
skin.
examination?
We can see the skin
What skin?
and
What is it called? Skin turgor.
skin
You
sugar
pinch
and
the skin, it doesn't fall back.
fall back on its
It remains standing,
and
then you
tongue.
can look at the tongue.
tongue of the patient. Patient was examined in supine position with arms resting by side and exposed from nipple to mid-thigh. On inspection, the abdomen was found to be distended. The umbilicus was not visualized. A midline scar extending 2 cm below Xiphi sternum to 7 cm above pubic symphysis was noted. The abdomen movements with respiration were normal. A swelling of size approximately 21 cm craniocaudally and 13 cm transversely was present in the midline involving the umbilical, epigastric and the hypogastric regions and extending laterally to involve both the hypochondriac, lumbar and the iliac regions. The swelling was irregular in shape with irregular margins. The surface was bossylated. A scar with visible striae was noted over the swelling. The cuff impulse test was negative. The swelling did not become prominent on the leg lifting or the head rising test. All other hernial orifices were normal. On palpation, all the inspectory findings were confirmed. The temperature of the swelling was normal. There was no tenderness. The swelling was irreducible. The abdomen was soft and there was no organomegaly. There was resonant note heard all over the swelling. The normal bowel sounds were present on auscultation. The per-rectal and the per-vaginal examination were found to be normal. Other systemic examinations were normal. So, to summarize my case, this is a case of a 49-year-old female with large recurrent abdominal swelling for 12 years. Swelling progressively became irreducible and was associated with pain and episodes of subacute intestinal obstruction. So, based on the history and clinical examination, I would like to ask the audience what could be the possibilities. Yes, sir. So, my provisional diagnosis based on the history and clinical examination was large, recurrent, irreducible incisional hernia with features of subacute intestinal
The
obstruction.
hernia may be irreducible and still not causing obstruction. How is that possible? You have an irreducible hernia, but there is no intestinal obstruction.
Sir, the content of the sac, there is no dense adhesions present between the sac and the content, so it does not cause, and the contents are not.
Yeah, but there is a history. So, hernia can be irreducible and still there may be no intestinal obstruction if the contents are omentum only. Isn't it? Now, in the past history, you said that after that emergency surgery, the post-operative period was uneventful. What do you mean by that?
Sir, if the surgical site infection occurs.
So, specifically you should mention that there was no history. Patient can tell you whether pus was coming out, whether sutures had to be removed early, whether the wound was left open. So, most important thing is that whether there was any evidence of wound infection, because that is the most important, most common predisposing factor for a hernia formation.
Can I make a comment as a non-surgeon? If you have such a large amount of gut just under the skin, and if you look at it carefully, you can almost always see peristaltic movements, right? Maybe that is one more thing you should have mentioned in the inspection, right?
Yes, sir. The routine blood investigations were done and were found to be normal. The CECT whole abdomen was done, and now I would like to call upon Dr. Krunal Mistry from the Department of Radiodiagnosis to discuss the CECT whole abdomen findings.
Respected dignitaries, I, Dr. Krunal Mistry from the Department of Radiodiagnosis, going to present the CCT whole abdomen finding of this case under the guidance of Dr. Swati Purohit Joshi ma'am. This is an axial CT scan of the patient demonstrating a hernial defect through with the small bowel loops and the transverse colon along with the mesenteric fat are seen herniating. Defect size of the hernia in the craniocaudal view is 20.2 cm in dimension and in the transverse plane was approximately 13 cm in diameter. Hernial sac volume was assessed by measuring the maximum craniocaudal, anteroposterior and the transverse dimension on imaging, and the calculated hernial sac volume was approximately 2317 cc. The abdominal cavity volume was assessed by the measuring the maximum craniocaudal, anteroposterior and the transverse dimension on imaging, where the height is taken from the upper edge of the liver to the pubic symphysis width from the transverse abdominis muscle on the both sides, and depth from the anterior surface of the vertebral column to the anterior abdominal wall, which gives an approximate abdominal cavity volume of 5020 cc. The summary of the CT findings were the large incisional hernia with the herniation of the small bowel loops, transverse colon associated with the mesenteric fat. There were no abrupt transition point identified, which suggests no definite obstruction.
Good morning, everyone. I am Dr. Devashish Verma, third year resident from Department of General Surgery, and I am going to present the further management of the patient. After CT imaging, our diagnosis is the large recurrent irreducible incisional hernia with loss of domain. In 2019, International Delphi Consensus of Expert Surgeons held at Europe, and they officially standardized the term loss of domain. It is defined as a hernia large enough such that simple reduction in its contents and primary facial closure either cannot be achieved without additional reconstructive techniques or cannot be achieved without significant risk of complications due to raised intra-abdominal pressure. It is also termed as second abdomen or abdomen within abdomen. In simpler terms, loss of domain means there is no space left in the abdomen to accommodate the herniated viscera that remains outside the abdomen. If we try to accommodate the viscera through the traditional surgery, it can lead to abdominal compartment syndrome. So we have to go for the additional advanced surgery techniques to increase the volume so that the herniated viscera can be replaced in the abdominal cavity. To calculate the loss of domain, there are two volumetric methods available. That is first Sabag method and second Tanaka method. In our case, we use Sabag method. We use Sabag method because Sabag method seems to be much easier than the Tanaka method, and Tanaka method is confusing and conceptually difficult, so most of the surgeons use Sabag method. It calculates the ratio of the hernia sac volume to the total peritoneal volume, where the total peritoneal volume is the volume of abdominal cavity plus the hernia sac volume. If the ratio comes out to be more than 20%, then we consider it as a loss of domain. We calculated the percentage of the loss of domain by Sabag method. It came out to be 32%, which is very high. It means that more than 1/3 of the abdominal volume was outside the abdomen. So in our case, loss of domain was 32%, as it was a very complex hernia. It was difficult for us to decide the further management, so we explored all the options available for the management. So goals of the surgery were adhesion lysis and reduction of the contents to the abdominal cavity without any iatrogenic perforation. Increase the volume of the abdominal cavity to accommodate the abdominal viscera. Reduce the risk of the abdominal compartment syndrome and recurrence. Tension-free midline facial closure with placement of the large mesh. Soft tissue reconstruction to give a new shape and scar to the abdomen. Keeping in mind the goals of the surgery, we explored all the options available for the further management of the patient. The techniques to increase the intra-abdominal volume are divided into the two. First, the pre-operative techniques, which consist of the botulinum toxin infiltration and pre-operative progressive pneumoperitoneum. Second, intraoperative techniques consist of the fasciotense and the component separation techniques. In botulinum toxin infiltration, in this technique, we inject botulinum toxin 3 to 4 weeks before the surgery under USG or CT guidance with a total dose of around 200 to 300 international units injected in the lateral abdominal wall. Due to the complications like injection related, that are infection, pain, hematoma, hypersensitivity reaction, urticaria, cardiopulmonary complications like dyspnea, respiratory failure, and even death. So we had excluded this technique for our case. Then we explored for the pre-operative progressive pneumoperitoneum. To use this technique, we place an intraperitoneal catheter under USG or CT guidance, through which we insufflate 500 to 1000 ml of air daily for 7 to 21 days. But due to the complication associated like subcutaneous emphysema, deep venous thrombosis, shoulder tip pain, pulmonary thromboembolism, port infection, respiratory failure, and even death, we didn't opted for this technique also. Then we look for the fasciotens. Fasciotens is a facial traction device that works on the principle of the controlled vertical traction. As this is used as adjunct with the botulinum toxin, we didn't opted for this technique in our case. So after exploring all the techniques, we found the component separation is the best modality available with least complication rates and is safer for our patient. So we use the component separation technique for further management of our patient.
Majority of the audience is non-surgical. You didn't tell us what does botulinum toxin do.
Sir, the botulinum toxin relaxes the muscle when we inject it. It basically it cleaves these synaptic proteins, snare proteins that inhibits the release of the acetylcholine.
Any other surgical condition where you know botulinum toxin can be used?
For the aesthetic surgeries, like we inject the Botox for the cosmetic purposes, sir.
Any GI related procedure as an alternative to a surgical procedure? Condition, yes.
In eclasia
Yes.
cardia.
Good.
Yes. So what is component separation technique? Component separation techniques refers to the creation of myofascial advancement flaps to assist the medialization of the rectus muscle and primary facial closure. Component separation technique is of two types. First is anterior component separation technique and posterior component separation. The anterior component separation involves the division of the external oblique muscle 2 cm lateral to the linea semillunaris, while the posterior component separation involves the division of the transversus abdominis muscle 0.5 to 1 cm medial to linea semillunaris. So to understand the component separation technique better, we should have the knowledge of anatomy of anterior abdominal wall. The layers of the anterior abdominal wall from the anterior to posterior include skin, subcutaneous tissue, superficial fascia, deep fascia, muscles, transversalis fascia, and peritoneum. The muscles of the lateral abdominal wall in superficial to deep fashion are external oblique muscle, internal oblique muscle, and transversus abdominis muscle, each with its own associated aponeurosis that contributes to the formation of rectus sheath. So the anterior rectus sheath is formed by the aponeurosis of external oblique muscle and the anterior lamella of the internal oblique muscle. Like here we can see the aponeurosis of the external oblique muscle and the anterior lamella of the internal oblique muscles are combining, and they are forming the anterior rectus sheath in anterior aspect of the rectus abdominis, while the posterior rectus sheath is formed by the posterior lamella of the internal oblique muscle and the aponeurosis of transversus abdominis muscle. These both anterior rectus sheath and posterior rectus sheath combine in midline and they form the linea alba. The rectus abdominis muscle lies in the midline between anterior rectus sheath and posterior rectus sheath. The line where the aponeurosis fuse from the anterior and posterior rectus sheath is known as linea semillunaris. So in anterior component separation, we cut the fibers of external oblique muscle, whereas in the posterior component technique, we cut the fibers of transversus abdominis muscle. So why we chose the posterior component separation technique? As in the anterior component separation technique, there are higher rates of the wound complications like skin necrosis, infection, hematoma, seroma, and delayed healing. There were higher recurrence rate in the anterior component separation. There was less medialization as compared to the posterior component separation technique. So our final surgical plan was abdominal wall reconstruction with transversus abdominis muscle release, that is TAR procedure. So we prepared the patient for further management. Pre-anesthetic checkup was done. incentive spirometry was started 2 days prior to the surgery. Pre-operative counseling was done. Bowel preparation was performed. Following are the operative steps of the TRAR procedure. At first, we gave the midline elliptical incision, then we excised the previous operative scar, that was of laparotomy performed. Then the adhesiolisis was done between the bowel, omentum, defect and anterior abdominal wall. Also, the interbowel adhesiolisis was done. Here is a small video. As you can see, there are dense adhesions present that were interbowel and in between the bowel and omentum. After adhesiolisis, we placed a normal saline soaked big mop to avoid any iatrogenic injury to the viscera. After placement of the mops, also called tar towel, posterior rectus sheath was incised 5 mm lateral to the midline to enter into the retrorectus plane and identify the fibers of the transversus abdominis muscle. After this, the transversus abdominis muscle was raised using the Lahey's forceps and the muscle fibers were divided 1 centimeter medial to the neurovascular bundles present. This approach was continued in the cranial as well as the caudal aspect of the plane. Further creation of tar plane. The tar plane was created by using peanut. The transversus abdominis muscle was lifted superiorly and separated from the underlying peritoneum. Now the posterior rectus sheath was closed and with continuous sutures. A proline mesh of size 30 into 30 centimeter was placed and incision was closed in layers. In the post-operative course, patient was mobilized and clear liquids were allowed in the post-operative evening. On the post-operative day 1, incentive spirometry was started. On the post-operative day 4, drain was removed. And on the day 5, the patient was discharged in vitally stable condition. On the post-operative day 12, sutures were removed. On the 6th month and first year follow-up, clinical examination and USG was done and there was no evidence of recurrence. There is no recurrence till now, no requirement of the analgesia and improved quality of life as of the 21st month follow-up, that is till now. Here are the pictures showing the comparison of the patient in pre-operative period and post-operative period. It can be clearly seen that there is a huge difference in the abdomen shape and contour abdomen, and we gave a new scar. This is a post-operative photo after 1 year. On the first year follow-up we had taken this. The review of literature. So why the laparoscopic ventral hernia repair was not done in our case? Because the laparoscopic ventral hernia is not indicated when the defect size is more than 10 centimeter in diameter, while in our case it was 13 centimeter. When there is loss of domain present, it is not indicated also. In our case, there was huge loss of domain as of the 32%. When extensive adhesiolisis is required, as it was done in our case, and when massive soft tissue rearrangement is required, which was done in our case. When we talk about the recurrence rates, it is reported as high as 30%, even in the expert hands. However, no recurrence has been observed in our case till date after 21 months. When we reviewed the literature for the defect size, we found that this defect size is not very common and only few cases have been reported in the literature of this size or more than this size when we operated this case. In June 2024, we had done this case. Based on the available records at our hospital and to the best of our knowledge, this represents the first TAR procedure and largest size ventral hernia with a loss of domain operated at our center. And now I would like to request Dr. Neel Kamal Gupta sir for the acknowledgement.
We are thankful to the management of Mahatma Gandhi Hospital, Radiology Anesthesia Department, CCR Review Committee, and especially Jaiswal sir, and the patient and the family members who shown their faith in us. As the sir said, when the patient came to us, it was around 2 years before, and at that time most of the surgeons, they do not have the knowledge of the TAR procedure or the advanced surgical procedures for the loss of domain. So before coming to us, not even outside, even in Jaipur, this patient went to many hospitals as well as the government and private medical colleges, well-known private and government medical colleges of Jaipur. They were wandering for the last 7 months, and it was the evening when the patient came to us. And when I show the picture in the evening at home, I was very much tense that what I will do. So in the morning when I said to the patient that these are the possibilities and we will operate the patient, the words of the patient son was कि सर आप पहले सर्जन हो जिसने ये कहा है कि इसको ऑपरेट करेंगे. हम कई जगह होकर आए लेकिन अभी तक किसी ने हमको ये नहीं कहा कि इसको का हम ऑपरेशन करेंगे. These are the appreciation, words of appreciation by the son of the patient.
नमस्ते, मेरा नाम सुधीर चौधरी है और मेरी मदरसा से हरनिया की समस्या थी जिसमें जयपुर के काफ़ी सारे बड़े रेप्यूटेड डॉक्टर्स ने मना कर दिया था उनको ट्रीट करने से. तो हमें किसी ने सजेस्ट किया कि हम महात्मा गांधी हॉस्पिटल में एक बार डॉक्टर नील कमल सर को दिखाएं और उनसे कंसल्ट करें. डॉक्टर नील कमल सर ने फिर उनको ट्रीट किया और एक अच्छे से बहुत ही बड़ा ऑपरेशन उन्होंने बहुत अच्छे तरीके से सक्सेसफुल किया और उनकी टीम ने और महात्मा गांधी हॉस्पिटल के मैनेजमेंट ने हमें इसमें पूरी तरीके से सपोर्ट.
थैंक यू.